Good morning. This morning I am going to talk about the fractures of the carpal bones. There are 8 carpal bones. Amongst all 8, scaphoid fractures are special because scaphoid most commonly fractured carpal bone. The incidence of scaphoid fractures estimated to be 15% of all wrist injuries. This is quite common. The mechanism of injury being fall on outstretched hand in 75% to 80% cases. Evaluation, history. The patient who complains of radial wrist pain after an injury, radial side of the wrist, complains of radial side of the wrist, pain at the radial side of the wrist, it has to be suspected. Then there comes physical examination and imaging. Physical findings are snuff box tenderness. This is the anatomical snuff box. I don't know whether you are able to see it or not. In scaphoid fractures, the tenderness is localized to this place. Scaphoid wrist waist exposed with ulnar deviation. Pain with palpation of scaphoid tuberosity. Limited painful wrist range of movement, especially forced dorsiflexion. Well, wrist movement is possible, but there is some restriction and there is some pain. Not excruciating pain like fracture of the distal end of radius. X-rays. The initial films are non-diagnostic in up to 25% of cases. It means in about 25% of cases, even if the patient is having a scaphoid fracture, the X-ray does not reveal it because either it is not properly positioned or a good quality X-ray is not there. So in those cases, if there is strong suspicion, then CT scan, MRI is also most accurate. In MRI, it shows the fracture very clearly. Bone scan is rarely used. So there are special views for diagnosing scaphoid fractures, such as PA of the wrist, this one, lateral of wrist. One is a scaphoid view, PA X-ray with wrist neutral and in ulnar deviation like this. This elongates the scaphoid to better visualize, and pronated oblique view like this. Look, this is the scaphoid bone. There lies the fracture. This is lunate triquetral pisiform, right? This may not be so clearly visible in the initial X-rays because there is not much displacement. Because of the simple reason is all these 8 carpal bones are very tightly arranged in the wrist joint. There is not much place. The radiolucent area, what you see here, is due to the presence of the articular cartilage, which is radiolucent. So there is not that much of space normally. This is basically a potential space. These radiolucent areas are due to presence of articular cartilage. So one may not be lucky to get an excellent X-ray view of the fracture scaphoid in the first X-ray. In those cases, CT scans are recommended. In CT scan, it's very clearly visible. There is some displacement and some angulation also. There is compression here, there is displacement here. This is called a humpback deformity. How do we classify the fracture scaphoid? The reason for classification is prognosis differs, typically by location. Either it's a proximal third fracture, or a middle third fracture, or a distal third fracture, or a tuberosity fracture. The middle third or waist fractures are most common. Why is fracture location so important in the scaphoid? Primary, this is the proximal part, this is the distal part, this is the tubercle. Primary vascular supply enters dorsal ridge here, from here, and runs retrograde to the proximal scaphoid. Starts here, then runs retrograde like this way. So, the more proximal the fracture, either here or here, there is chance of healing complications. The more proximal is the fracture, there are likely to be complications for healing. Management of suspected scaphoid fracture. Clear injury and positive examination with normal X-rays. Even if there is X-rays do not reveal the fracture, as in about 25% of cases, if there is clinical suspicion of scaphoid fracture, the hand is immobilized in a plaster, complete plaster, thumb spica, that means you include the thumb, plus up to this. Then after 7 to 10 days, again X-rays are taken. There's every possibility that this may reveal the fracture. If repeat X-rays, if patient is still symptomatic, if pain still present but X-ray continues to be normal, then consider MRI early. Then recast and follow up at 3 weeks again. If acute diagnosis is necessary but X-ray does not reveal a fracture, then one should consider a MRI or CT. The treatment options are in acute injuries. Either it's a non-operative, either it's a short versus long arm cast. Long arm means including the elbow, or a short arm cast up below the elbow, plus preferable to include the thumb including the thumb, or operative, percutaneous pin or screw fixation, or open reduction internal fixation. Cast treatment of non-displaced scaphoid waist and distal pole fractures is safe, effective, reliable and reproducible. Distal pole fractures, there is no problem with vascularity, they almost always heal. In scaphoid waist fractures also, if it is non-displaced, almost all of them heal. But if the fracture is displaced fractures clearly benefit from open reduction internal fixation. For experienced surgeons who do it regularly, wrist surgeons or upper extremity surgeons, open reduction internal fixation may return patients to work faster and lower rehabilitation costs, because typically a scaphoid fracture being treated conservatively by plaster immobilization, that requires at least 10 weeks of plaster immobilization, 2.5 months. So, open reduction internal fixation may return patients to work faster. Well, they will be able to use the right hand in case of all daily activities, not necessarily strenuous activities such as writing, eating. These can be done very early. With advent of percutaneous techniques, early fixation is becoming more appealing. So more and more surgeons are doing a early fixation. What are the definitive indications for surgery? If the displacement is more than 1 millimeter, there are some deformities at the scaphoid, humpback deformity, then these are indications for surgery. And some scaphoid fractures fail to heal, they end up in non-union. Definitely those symptomatic non-union, those are to be treated by surgery. Typically, scaphoid fractures are internally fixed by Harbert screws. You can see there is the scaphoid bone is almost completely covered all around by articular cartilage. So that's why there should not be any head. I mean, these diameters are different. That gives compression. I mean, there was a gap initially. When this one also goes in, this gap closes. That gives compression. The fracture line is almost obliterated. This is a scaphoid Harbert screw. This is a Harbert screw. The screw looks like something different from usual screws. This is a good invention by Harbert that gives very good results. Outcomes and complications. This patient had a fractured scaphoid here, fracture of the proximal pole. It has failed to unite, and this is denser, sclerosed. So these are dead bone. This is a AVN, a vascular necrosis of the proximal pole. Or it could be non-union also. This is a non-union. Malunion, arthritis of the wrist. If there is a scaphoid, this is a fractured scaphoid, this is lunate. So these are the sclerosis at the opposing fracture surfaces. This is radiolucent area is there. That means it's non-union. How do you treat it? It's open reduction, internal fixation with the same Harbert screws plus interposed bone graft, cancellous bone grafts. Or open, if there is too much of shortening, open reduction, internal fixation with structural tricortical graft from ileum. Or there are newer operations, open reduction, internal fixation with vascularized graft. They take a piece of bone, chunk of bone with its blood supply intact. That is to be taken from here with the vascular pedicle intact. Then this is placed inside the gap. So it's a vascularized graft. Well, that needs a microsurgical technique, but it still is being done. Scaphoid non-union is a challenging problem with significant risk for the wrist. Left untreated, scaphoid non-unions have a near 100% rate of degenerative disease. If approached appropriately, scaphoid healing may be achieved. The next part of my lecture is Bennett's fracture. It's a fracture dislocation first described by Bennett in 1882. This is a Bennett's fracture. This bone fragment remains here and the first metacarpal is displaced by the pool of adductor pollicis. Adductor pollicis. How this is fixed? There is a traction there. One has to pull the thumb, traction, then it goes back into the joint. Then it's, luckily all the ligaments are there, so it puts back into position. Then you fix this by either a K-wire here or even by two K-wires, or if this fragment is very big, even one can use a screw, or there could be a supplementary intermetacarpal wire, that is between a first and second metacarpal. Or the easiest or the commonest technique is somebody pulls by the tip by holding the thumb, then it automatically gets reduced. To hold it in place, one K-wire is placed like this. Someone puts a thumb pressure here, otherwise this will come out again this way. So by the thumb pressure here, this is pulled back to the joint, then it is fixed to the this trapeziometacarpal joint is fixed, temporarily stabilized till it heals. So this is the X-ray picture. This is how this is. This one was subluxated. This one was subluxated, and the one small fragment remained there. So you push it here, so that it gets back, then you fix it. There is no need to fix these two fragments. This is another example, the same. This one, put pressure there, the first metacarpal is reduced, and automatically this fragment also gets reduced. Then you fix with a K-wire. This joint, carpometacarpal joint, is fixed. This is another picture. Here 2 K-wires are used. Here here the joint was left alone, only the 2 fragments were fixed. Here 2 fragments were fixed. The joint was not stabilized. This is also another technique of internal fixation. That's all. They always give excellent results, but after open reduction or either close reduction and internal fixation. If there is a delay in seeking treatment, then one may have to go for a open reduction internal fixation. In that case also, the result is very good. Thank you very much for your attention. Next class will be on fracture pelvis.